Ventilator screen, alarms going off, peak pressure rising, saturation drifting, the tube is in, the lungs are not happy. Tonight we cover mechanical ventilation and non-invasive ventilatory support, the settings, the strategies, and the sabotage when it all goes wrong. Case 1. 68-year-old woman woke from sleep gasping, severe dyspnea, blood pressure 198/112, heart rate 110, respiratory rate 32, jugular venous distension, bilateral crackles to the apices, frothy pink sputum at the corners of her mouth, oxygen saturation 84% on a non-rebreather. She is anxious, awake, following commands. The question: does this patient get a tube or does she get a mask? The tube is in. Now what? We covered intubation in Chapter 1. Today, the patient is sedated, paralyzed, on the ventilator, and you own every breath. 3 decisions, 5 settings, and 1 reassessment loop that catches the disasters before they kill. Case 2. 24-year-old man with severe asthma. 3 days of progressive wheezing despite his home inhalers. Now in the resuscitation bay, obtunded, peak flow unmeasurable, accessory muscles failing. Already received continuous albuterol, ipratropium, magnesium, intravenous steroids, about to be intubated. The question, once the tube is in, what settings keep him alive instead of killing him with the very ventilator that is supposed to save him? Case 3. 55-year-old man, septic shock from community-acquired pneumonia, intubated 2 hours ago. On the ventilator at 100% oxygen with PEEP of 10, arterial oxygen of 70, P/F ratio of 70, severe ARDS by Berlin criteria, bilateral infiltrates on the chest film. The question, what changes about the way you ventilate this patient compared to the routine intubation? Because routine settings will kill him. 3 reasons your patient needs help breathing. 1. Hypoxemic failure. The lung is wet, consolidated, or collapsed. The oxygen will not cross. 2. Hypercapnic failure. The patient cannot move enough air. CO2 climbs, pH falls. 3. Failure to protect. Mental status is gone, secretions are pooling, the airway will not stay open. Match the failure to the tool. Hypoxemic with a reversible cause, try CPAP or high flow. Hypercapnic with a reversible cause, try BiPAP. Failure to protect, that is a tube. The win conditions for non-invasive ventilation. 5 things have to be true. 1. The underlying problem is rapidly reversible. Bronchodilators are kicking in, diuretics are about to work. 2. The patient is awake. 3. The patient can cooperate with a tight-fitting mask. 4. Hemodynamics are adequate. NIV drops the blood pressure if preload is borderline. 5. The airway is protected. The patient can handle their own secretions. If all 5 are true, mask first, tube later, if needed at all. The 2 NIV diagnoses where the evidence is overwhelming. COPD exacerbation, non-invasive ventilation reduces intubation by 65%, decreases hospital length of stay, and improves mortality with a number needed to treat of 12. 12. Acute cardiogenic pulmonary edema. NIV reduces intubation by 50% and reduces mortality with a number needed to treat of 17. Both work whether you use CPAP or BiPAP. These are the wins. If your patient has either of these 2 presentations and meets the 5 criteria, mask first. When NIV fails, absolute reasons not to try. Apnea or respiratory arrest, intubate now. Inability to protect the airway. Facial trauma, recent upper airway surgery, or anything that prevents a mass seal. Hemodynamic instability, active vomiting or massive secretions, an uncooperative patient who tears off the mask, and the board trap, pneumonia. Pneumonia is an independent predictor of NIV failure, and a failed trial of NIV in pneumonia is associated with higher mortality than immediate intubation. If pneumonia is the dominant problem, do not bet on the mask. CPAP versus BiPAP. CPAP delivers a single continuous pressure throughout the respiratory cycle. Use it when the problem is oxygenation and recruitment. Classically, cardiogenic pulmonary edema. BiPAP alternates between higher pressure on inspiration and lower pressure on expiration. Use it when the patient needs help moving air. Classically, COPD exacerbation with hypercapnia. Start BiPAP at inspiratory pressure of 10, expiratory pressure of 5. Titrate by 2 centimeters at a time. Keep inspiratory pressure under 20 to avoid gastric insufflation. Back to our flash edema patient. Full face mask, CPAP at 10, reassess in 1 hour. CPAP physiology and cardiogenic pulmonary edema. Why does a simple mask save the failing heart? 3 mechanisms. 1. Positive intrathoracic pressure reduces the transmural gradient across the left ventricle. Lower transmural pressure means lower afterload. The failing ventricle ejects against less resistance. 2. positive end expiratory pressure recruits flooded alveoli and shifts fluid out of the airspace. Oxygenation climbs without raising the inspired oxygen. 3. Increased intrathoracic pressure decreases venous return. Preload falls, the overloaded ventricle gets a break. Net effect, improved cardiac output, improved oxygenation, reduced work of breathing. Back to our flash edema patient. CPAP at 10 centimeters of water is treating her heart failure as much as it is treating her lungs. High flow nasal cannula, oxygen on steroids, flow rates up to 60 liters per minute. Humidified, heated, and matched to inspiratory demand. Washes out anatomic dead space. Delivers a small amount of positive end expiratory pressure, 1 to 3 centimeters of water. Typical starting settings. Fraction of inspired oxygen at 50%, flow at 40 liters per minute. The indication is hypoxemic respiratory failure without significant hypercarbia. The Florally trial showed a mortality benefit over standard oxygen and over non-invasive ventilation in that exact population. Patient stays calm, the upper airway stays patent, and you avoid the mask intolerance problem. The ROX Index, a simple bedside tool to predict who will fail high-flow nasal cannula. The formula, oxygen saturation divided by fraction of inspired oxygen, all divided by respiratory rate, measured at 2 hours, 6 hours, and 12 hours after initiation. 2 thresholds you should know. Under 3.85, high risk of failure, escalate the support. Over 4.88, likely to succeed, stay the course. Anything in between, reassess clinically and trend. It is not perfect, but it is better than guessing. Volume control versus pressure control, the single biggest dichotomy in invasive ventilation. Volume control, you set the tidal volume. The ventilator delivers that exact volume on every breath. Pressure becomes the variable, and it rises if compliance drops. Use volume control when you need guaranteed minute ventilation. ARDS, obesity, severe burns. Pressure control, you set the inspiratory pressure. The ventilator holds that pressure for a set inspiratory time. Tidal volume becomes the variable. Pressure is capped, which protects against barotrauma, useful in severe asthma and COPD. For the routine ED intubation without a specific indication, either is acceptable. Most ED ventilators default to assist control volume control. Start there. Assist control, the ED default mode. Every breath, whether triggered by the patient or delivered by the backup timer, is fully supported by the ventilator. If you set a rate of 14, the patient gets at least 14 full-size breaths per minute. If the patient triggers extra breaths, they each get fully supported too. Most ED patients are paralyzed and sedated, so they trigger little or nothing. Assist control gives them everything. The catch, once the paralytic wears off, if the patient starts triggering at 30, every triggered breath is full size, which causes hyperventilation, breath stacking, and ventilator dysynchrony. Sedate adequately. SIMV and pressure support. What they are and why we usually skip them in the ED. SIMV, synchronized intermittent mandatory ventilation. Mandatory breaths at the set rate, synchronized with patient effort. Extra patient triggered breaths get pressure support, not full-size breaths. Less hyperventilation than assist control, but more work of breathing for the patient. Pressure support ventilation, no mandatory breaths at all. The patient breathes spontaneously and every breath gets a pressure boost. Useful for the awake intubated patient who is approaching extubation. Bottom line, default to assist control in the freshly intubated patient. SIMV and pressure support come later, on the way to a tube out. The 5 settings you must enter on every freshly intubated patient. 1. Mode. Assist control volume control unless you have a reason to choose otherwise. 2. Tidal volume. 6 to 8 milliliters per kilogram of ideal body weight. 3. Respiratory rate. 12 to 14, or match the patient's pre-intubation rate if it was higher. 4. PEEP. 5 centimeters of water as a default. 5. Fraction of inspired oxygen. Start at 100% and titrate down within the first hour. 5 dials. Get them right, you have time to think. Get them wrong, and you create the next ED disaster. Ideal body weight. Do the math every time. For men, 50 kilograms plus 2.3 kilograms for each inch over 5 feet. For women, 45.5 kilograms plus 2.3 kilograms for each inch over 5 feet. Use height, not actual weight. A 5'4" woman weighing 100 kilograms. Her ideal body weight is 45.5 plus 4 times 2.3, which is 54.7. At 6 milliliters per kilogram, her tidal volume is 330. Not 600, 330. The lungs do not get bigger because the patient does. Do not skip the math. PEEP, positive end expiratory pressure, your friend and your foe. The friend, PEEP, keeps alveoli open at end expiration, recruits collapsed lung, improves oxygenation, reduces intrapulmonary shunt, start at 5 centimeters in nearly every adult. The foe, PEEP raises intrathoracic pressure, reduces venous return, drops cardiac output, and drops blood pressure. PEEP can overdistend focal disease like a lobar pneumonia, making things worse. Increase PEEP in ARDS up the ladder. Hold PEEP low, even at 0, in pure status asthmaticus, where it can worsen breath stacking. Back to our flash pulmonary edema patient. PEEP is part of why CPAP at 10 was the right move. Fraction of inspired oxygen. Start at 100%, drop it as fast as you can. The target, the lowest level that keeps oxygen saturation above 90, ideally between 88 and 94%. Hyperoxia is not benign. In a recent ED cohort study, arterial oxygen above 120 millimeters of mercury was an independent predictor of hospital mortality in mechanically ventilated patients. Hyperoxia generates free radicals, worsens reperfusion injury, and may directly damage lung tissue. The reflex to leave the patient on 100% oxygen because the saturation is 100 is wrong. Titrate down every hour. Peak inspiratory pressure versus plateau pressure. The number on the ventilator screen during inhalation is the peak. The peak includes airway resistance and circuit resistance. It is not the pressure your alveoli are seeing. Plateau pressure is what the alveoli see. To measure it, you push the inspiratory hold button on the ventilator. The valve closes at end inspiration. Flow stops. Resistance drops out of the equation. The number that settles is the plateau. That is the alveolar pressure. That is the number that matters for lung protective ventilation. Push the button. Read the plateau. Plateau pressure. Keep it under 30 centimeters of water. That is the lung protective threshold. Above 30, you are actively causing ventilator-induced lung injury. 4 mechanisms. Barotrauma, the gross alveolar rupture leading to pneumothorax or pneumomediastinum. Vol-U trauma, alveolar overdistension from too much tidal volume. Adalec trauma, the shearing injury from repeated alveolar opening and closing. And biotrauma, the inflammatory cascade that travels from injured lung to the rest of the body. Newer evidence, driving pressure, which is plateau minus PEEP, kept under 15 may matter even more than the absolute plateau. Drop the tidal volume, tolerate the gas. The lungs heal if you stop hurting them. Back to case 2, status asthmaticus on the ventilator. Obstructive lung disease, asthma, or COPD gets a special strategy. The single goal, give the lungs enough time to exhale. Settings, tidal volume 6 to 8 milliliters per kilogram ideal body weight. Respiratory rate slow, 8 to 10 breaths per minute. Inspiratory to expiratory ratio of 1 to 4. Long expiratory time. PEEP low, 0 to 5 centimeters in pure asthma. Fraction of inspired oxygen titrated to saturation between 88 and 94. Accept the CO2. Permissive hypercapnia. Tolerate the pH down to 7.15. Sedate deeply. Sometimes paralyze. Buy the lungs time. Breath stacking. Auto-PEEP. Intrinsic PEEP. Dynamic hyperinflation. Same phenomenon, 4 names. The expiratory flow does not return to baseline before the next breath is delivered. Air gets trapped. End expiratory volume climbs. End expiratory pressure climbs. The flow time tracing tells you, look at the expiratory phase. If it does not flatten out, air is being trapped. Consequences, high airway pressures, falling cardiac output from squeezed venous return, hypotension, and ultimately pulseless electrical activity arrest. This is the number 1 cause of death in the mechanically ventilated asthmatic. Recognize it before the code. The asthmatic on the vent who suddenly crashes. Blood pressure drops. Peak pressures climb. The reflex move is to call for fluids, push pressors, or shock the rhythm. The right move is simpler. Disconnect from the ventilator. Hands on the chest. Help the patient exhale. Gentle external pressure if needed. Watch the saturation. Watch the blood pressure. As trapped air leaves the lungs, intrathoracic pressure falls, venous return recovers, and the blood pressure comes back. Then reconnect at a lower respiratory rate, longer expiratory time, smaller tidal volume. Disconnect and bag. Memorize it. Applied PEEP in COPD. Counterintuitive but important. In the COPD patient who is spontaneously triggering the ventilator but failing to trigger effectively, add applied PEEP. Set it to roughly 80% of the measured auto-PEEP. Why? Because the patient has to overcome their own intrinsic PEEP before the ventilator senses inspiratory effort. Matching the applied PEEP narrows the gap, makes triggering effective, reduces work of breathing, improves synchrony. The distinction matters. Pure asthma, keep PEEP minimal. COPD with ineffective triggering, match the auto-PEEP. 2 diseases, 2 approaches. Ours back to case 3, our septic shock patient with bilateral infiltrates and a P over F ratio of 70. The ARDSnet protocol. Tidal volume of 6 milliliters per kilogram ideal body weight. Plateau pressure under 30. PEEP titrated up using the standard PEEP and oxygen ladder. Permissive hypercapnia tolerated to pH 7.15. Prone positioning if oxygen over fraction of inspired oxygen stays under 150 despite optimization. The ARMA trial in 2000 showed a relative mortality reduction of 22% with the low tidal volume strategy. This is foundational EM critical care. Memorize it. The Berlin definition of ARDS. 4 criteria. 1. Acute onset within 1 week of a clinical insult or worsening respiratory symptoms. 2. Bilateral opacities on chest imaging, not fully explained by effusion, atelectasis, or nodules. 3. Not fully explained by cardiac failure or fluid overload. 4. Severity stratified by the P over F ratio while on at least 5 centimeters of PEEP. Mild, P over F 200 to 300. Moderate, P over F 100 to 200. Severe, P over F under 100. Severity drives intensity of intervention, prone positioning, neuromuscular blockade, ECMO consideration. The distressed ventilated patient. First move, always. If the patient becomes acutely unstable, disconnect from the ventilator. Bag manually with 100% oxygen, then watch what happens. If hypotension resolves with disconnection, the cause was Auto-PEEP. If hypotension does not resolve, suspect tension pneumothorax until proven otherwise. Decompress. Needle thoracostomy in the second intercostal space, midclavicular line, or fifth intercostal space, anterior axillary line. Finger thoracostomy if you are confident. Then chest tube. The ventilator is not the test of life. Manual bagging is the test. Use it. DOPES. The mnemonic that runs every crashing vent patient. D. Displacement. Tube migrated into a mainstem bronchus, slipped into the esophagus, or fell out entirely. O. Obstruction. Tube kinked, mucus plug, blood clot, foreign body. P. Pneumothorax. Tension until proven otherwise. E. Equipment failure. Disconnected circuit, valve malfunction, oxygen supply lost. S. Stacking. Auto-PEEP and breath stacking, especially in obstructive disease. Run the list every time. Our status asthmaticus patient. If he crashes, dopes him. Stacking is the leading cause. Disconnect, bag, decide. The alarms. 2 flavors. High pressure alarm, the most common. The ventilator is meeting more resistance or less compliance than it expects. Differential. Secretions, mucus plug, kinked tube, biting on the tube, bronchospasm, tension pneumothorax, mainstem migration, worsening ARDS, low pressure alarm, the less common. The ventilator is meeting less resistance than expected, usually because air is escaping. Differential, circuit disconnection, cuff rupture, accidental extubation. The alarm is your friend, it is information. Silence it only after you have figured out the cause. High peak inspiratory pressure with high plateau pressure. Both numbers go up together. That tells you the lung or chest wall got stiffer, a compliance problem. Differential, worsening ARDS, tension pneumothorax, pulmonary edema, abdominal compartment syndrome, or massive ascites pushing up on the diaphragm, inadequate sedation with the patient fighting the vent. The treatment depends on the cause. More PEEP and protective settings for ARDS, decompression for pneumothorax, diuresis for overload, more sedation for the fighter. Diagnose the compliance problem, fix it. High peak inspiratory pressure with normal plateau pressure. The peak went up, but the plateau did not. That tells you the airway or the circuit got narrower, a resistance problem. Differential, bronchospasm, kinked endotracheal tube, mucus plug, blood clot, patient biting the tube, foreign body in the circuit, water condensation in the tubing. Pass a suction catheter, check the bite block, listen to the chest, bronchodilator if wheezing. This is the single highest yield ventilator troubleshooting concept on the boards. Memorize the 2x2. Low pressure alarm. Sudden drop in airway pressure. Find the leak. Walk the circuit from the wall to the patient. Check every connection. Inspect the tube. Listen at the mouth for an air leak around the cuff. If you hear it, re-inflate the cuff to a pressure of 20 to 30 centimeters of water. If the tube has fallen out, you need to re-intubate. If the tube has migrated up out of the vocal cords, you may be able to reposition under direct visualization. Confirm with end-tidal CO2 once tube is back in place. The end-tidal CO2 waveform tells you more than the number. Normal, a clean square wave with a flat plateau. Shark fin, the upstroke slants, no clean plateau. That is obstruction. Asthma, COPD, mucus plug. Curare cleft, a notch in the plateau. That is the patient making spontaneous inspiratory effort against the ventilator. Redose sedation or paralytic if appropriate. Sudden drop to zero, disconnect, extubation, or arrest. End-tidal CO2 keeps confirming tube placement every single breath. Watch the waveform, not just the number. Pain first, then sedation. The intubated patient is uncomfortable. Treat the pain before chasing agitation with more sedative. Fentanyl 25 to 50 micrograms intravenous push every 5 to 15 minutes or a continuous infusion. Then sedation. The ED default, propofol infusion starting at 5 to 20 micrograms per kilogram per minute. Titrated up. Watch for hypotension. Propofol drops the pressure. Dexmedetomidine is an alternative, 0.2 to 1.5 micrograms per kilogram per hour, for the patient who needs lighter sedation. Do not use dexmedetomidine alone in the freshly paralyzed patient. Pain causes agitation. Treat the pain. The Richmond Agitation Sedation Scale, RASS, the ICU standard, +4, combative, immediate danger to staff, +1, restless, anxious, 0, alert and calm, -2, light sedation, briefly awakens to voice, -4, deep sedation, no response to voice but movement to physical stimulation, -5, unarousable. The target for most ED ventilated patients, -2 to 0, lighter than you think. Deeper sedation only if actively paralyzed or undergoing a procedure. Light sedation reduces ventilator days, reduces delirium, and reduces mortality. Aim for awake and calm, not unconscious. The rocuronium trap. From Chapter 1, still true here. Etomidate wears off in 5 to 10 minutes. Rocuronium lasts 45. After your intubation, the patient is lying still on the gurney, eyes closed. They look calm. They are not calm. They are paralyzed. They may be fully conscious. Push analgesia, push sedation. Do not wait for an assessment that cannot be valid in a paralyzed patient. Awake paralysis is a humanitarian and medico-legal disaster. The very moment the tube is confirmed, fentanyl, propofol, then breathe. Neuromuscular blockade after intubation. Routine paralytic infusions are no longer recommended, even in moderate to severe ARDS. The early signal from the Ascurus trial did not replicate in the larger ROSE trial. Reserve continuous neuromuscular blockade for 2 indications: refractory ventilator dysynchrony despite adequate sedation, and refractory hypoxemia. When you do need it, the preferred agent is cisatracurium infusion because its metabolism is independent of liver and kidney function, and if you paralyze, you sedate deeply. RASS -5, always. Ventilator-associated pneumonia prevention. The bundle, 6 elements. 1. Head of bed elevated to 30 degrees. 2. Oral care with chlorhexidine. 3. Subglottic suction if the endotracheal tube has the port for it. 4. Daily sedation interruption, the spontaneous awakening trial. 5. Daily spontaneous breathing trial in the appropriate patient. 6. Deep vein thrombosis prophylaxis and peptic ulcer disease prophylaxis. About 50% of ventilator-associated pneumonias arise in the first 4 days. The bundle starts in the ED, head of bed up the moment the tube is confirmed. Prone positioning. For moderate to severe ARDS, when the P/F ratio stays under 150 despite optimized PEEP and fraction of inspired oxygen. The Pro-CVO trial in 2013, prone for 16 hours per day, reduced 28-day mortality. Mechanism: better matching of ventilation to perfusion, recruitment of dorsal lung units, more uniform stress and strain distribution. Logistically, needs a trained turn team of 4 to 5 staff to roll the patient safely. Increasingly initiated in the emergency department for boarded ARDS patients when the ICU bed is hours away. Back to case 3. If our septic ARDS patient stays under that P/F of 150, prone him. Extubation readiness. Rare in the ED, but increasingly relevant given long boarding times. The checklist. Underlying problem reversed or clearly reversing. Awake, following commands. Adequate cough. Secretions manageable with intermittent suctioning. Oxygenation acceptable. P/F greater than 200. PEEP at 5 or less. Fraction of inspired oxygen at 40% or less. Passed a spontaneous breathing trial. At minimal pressure support for 30 to 120 minutes. Cuff leak present if there is concern for laryngeal edema. Hit all the criteria, pull the tube. Miss 1, wait. Pediatric ventilator considerations. The same lung protective principles apply to children. 6 to 8 milliliters per kilogram ideal body weight tidal volume. The big differences are rate and tube. Respiratory rate is higher at baseline. Infants 25 to 30, toddlers 20 to 25, school age 16 to 20, adolescents 12 to 16. Cuffed endotracheal tubes are now preferred in most modern pediatric practice, including infants. PEEP at 5 is a standard start. The ARDS protective strategy applies in pediatric ARDS too, though the pediatric ARDS literature uses slightly different P/F thresholds. Bottom line, kids get the same lung protection. Set the rate higher. 8 things you will not forget. 1. Non-invasive ventilation wins in COPD exacerbation and acute cardiogenic pulmonary edema. Pneumonia is a predictor of NIV failure. 2. CPAP and BiPAP are clinically equivalent. Pick the tool that fits the failure. 3. Initial settings on the freshly intubated adult. Assist control volume control. Tidal volume 6 to 8 milliliters per kilogram ideal body weight. Rate 12 to 14. PEEP 5. Fraction of inspired oxygen 100% and titrate down. 4. Plateau pressure under 30. Driving pressure low. Tolerate the CO2. 5. ARDS gets low tidal volume, 6 per kilogram. Higher PEEP if needed. Prone if P over F stays under 150. 6. Obstructive lung disease gets slow rate, long expiratory time, low PEEP. Breath stacking causes hypotension and arrest. Disconnect and bag. 7. DOPES the crashing ventilated patient. High pressure means resistance or compliance. Low pressure means leak. 8. Sedate light, RASS -2 to 0. Pain first, then sedation. The patient is still awake under the rocuronium. Remember. Documentation pearls. Indication for intubation in the 3 criteria language from Chapter 1. Failure to maintain or protect. Failure of oxygenation or ventilation. Anticipated clinical course. Initial ventilator mode and settings, including the ideal body weight you use to calculate tidal volume. Plateau pressure if measured. RASS score after sedation initiation. Head of bed elevated. Cuff pressure checked. Critical care time documented. Every intubated patient qualifies, and the boarded ventilated patient may qualify for hours of it. Document the clinical reasoning. The chart protects you and the next clinician. Next time, shock, recognition, classification, resuscitation. You secured the airway, you ran the ventilator, now the blood pressure is dropping. Why, what kind, what now? See you there.